8.1 CNS Regulation, Mood, and Cognition Introduction. Learning Objectives. 1. Identify the classifications and actions of drugs related to the central nervous system, mood, and cognition. 2. Consider examples of when, how, and to whom CNS, mood, and cognition drugs may be administered. 3. Identify the side effects and special considerations associated with CNS, mood, and cognitive therapy. 4. Identify considerations and implications of using CNS, mood, and cognitive medications across the lifespan. 5. Consider evidence-based concepts when using the nursing process, clinical reasoning, and decision-making related to medications that affect the CNS, mood, and cognition. Key terms: action potential, acute dystonia, affect, akathisia, anxiety, blood-brain barrier, bradykinesia, central nervous system, chemical synapse, cognition, dress, dystonia, mood, nerve, neuroleptic malignant syndrome, neurons, mechanism of action, methicillin-resistant S. aureus, narrow-spectrum antimicrobial, pathogen, prototype, resistance, sensitivity analysis, superinfection, synergistic interaction, time-dependent, trough, vancomycin-resistant S. aureus. The nervous system is a very complex organ system. Even though progress has continued at an amazing rate within the scientific discipline of neuroscience, our understanding of the intricacies within this science is limited. The nervous system may be just too complex for us to completely understand, and you may notice evidence of this within some of the mechanisms of action statements later in this chapter where exact understanding is unknown. The complexity of the nervous system and understanding of the brain can make treating and preventing diseases that affect the system complicated. 8.2 CNS Regulation, Mood, and Cognition Concepts. Concepts related to the CNS, mood, and cognition. This resource provides a basic introduction to the concepts related to the central nervous system and cognition in connection with pharmacology. The concept of cognition is defined as the process of thought that embodies perception, attention, visuospatial, cognition, language, learning, memory, and executive function with a higher order, thinking skills of comprehension, insight, problem-solving, reasoning, decision-making, creativity, and metacognition 1. This chapter also addresses mood, affect, and anxiety. The concept map in Figure 8.2 summarizes information related to the concept of mood, affect, and the CNS-5. You are encouraged to revisit this map after you have completed the chapter. You may also wish to develop your own concept map related to other CNS concepts in this chapter. 2. Gene Giddens, Concepts of Nursing Practice, 2nd edition, page 299. 5. Gene Giddens, Concepts of Nursing Practice, 2nd edition. Figure 8.2, a mood and affect concept map, overview of the central nervous system and processes. Before we can begin to understand how different medications influence the brain, we need to review the central nervous system. The nervous system can be divided into two major regions, the central and peripheral nervous systems. The central nervous system is the brain and spinal cord, and the peripheral nervous system is everything else. The brain is contained within the cranial cavity of the skull, and the spinal cord is contained within the vertebral cavity of the vertebral column. It is a bit of an oversimplification to say that the CNS is what is inside these two cavities, and the peripheral nervous system is outside of them. But that is one way to start to think about it. In actuality, there are some elements of the peripheral nervous system that are within the cranial or vertebral cavities. The peripheral nervous system is so named because it is on the periphery, meaning beyond the brain and spinal cord. Depending on different aspects of the nervous system, the dividing line between central and peripheral is not necessarily universal. The peripheral nervous system is further divided into the autonomic nervous system and the somatic nervous system, which are further discussed in the autonomic nervous system chapter in this book. Figure 8.2. B. The central and peripheral nervous system. 6. This work is a derivative of Anatomy and Physiology by OpenStax, licensed under CC by 4. Access for free at Books, Anatomy and Physiology. Pages 1 Introduction. 7. 1201 Overview of Nervous System. JPG by OpenStax is licensed under CC by 4. Access for free at Anatomy and Physiology, pages 12 to 1 Basic Structure and Function of the Nervous System. 8. 1205 Somatic Autonomic Enteric Structures -N.jpg by OpenStax is licensed under CC by 4. Access for free at Books, Anatomy and Physiology, pages 12 to 1 Basic Structure and Function of the Nervous System. Figure 8.2. See somatic, autonomic, and enteric structures of the nervous system. Review more detailed information about the nervous system function using this OpenStax link, Basic Structure and Function of the Nervous System. Communication in the nervous system. Your brain communicates with electrical impulses that signal a release of a neurotransmitter, which then binds to the targeted cell. Understanding this communication will help you put the pieces together when you are trying to understand the mechanism of action of medication that works by influencing neurotransmitters. See Figure 8.2D for an illustration of the major elements in neuron communication. Figure 8.2D, major elements in neuron communication. There are two types of connections between electrically active cells, chemical synapses and electrical synapses. In chemical synapse, a chemical signal, namely a neurotransmitter, is released from one cell and affects another cell. In comparison, in an electrical synapse, there is a direct connection between the two cells so that ions can pass directly from one cell to the next. In this unit, we will be focusing on the communication of a neurotransmitter in a chemical synapse. Once in the synaptic cleft, the neurotransmitter diffuses the short distance to the postsynaptic membrane and can interact with neurotransmitter receptors. Receptors are specific for the neurotransmitter, and the two fit together like a key and lock. One neurotransmitter binds to its receptor and will not bind to receptors for other neurotransmitters, making the binding a specific chemical event. Figure 8.2E, major elements in neuron communication. When the neurotransmitter binds to the receptor, the cell membrane of the target neuron changes its electrical state, and a new graded potential begins. If that graded potential is strong enough to reach threshold, the second neuron generates an action potential. The target of this neuron is another neuron in the thalamus of the brain, the part of the CNS that acts as a relay for sensory information. The thalamus then sends the sensory information to the cerebral cortex, the outermost layer of gray matter in the brain, where conscious perception of that stimulus begins. A supplementary video explaining neuron communication via action potentials is provided below. One or more interactive elements has been excluded from this version of the text. You can view them online here, msbc.ca, types of neurotransmitters, amino acids. One group of neurotransmitters is amino acids. GABA is an example of an amino acid neurotransmitter. They each have their own receptors and do not interact with each other. Amino acid neurotransmitters are eliminated from the synapse by RE uptake. A pump in the cell membrane of the presynaptic element, or sometimes a neighboring glial cell, will clear the amino acid from the synaptic cleft so that it can be recycled, repackaged in vesicles, and released again. Biogenic amine. Another class of neurotransmitters is the biogenic amine, a group of neurotransmitters that are enzymatically made from amino acids. For example, serotonin is made from tryptophan. It is the basis of the serotonergic system, which has its own specific receptors. Serotonin is transported back into the presynaptic cell for repackaging. Other biogenic amines are made from tyrosine and include dopamine, norepinephrine, and epinephrine. Dopamine is part of its own system, the dopaminergic system, which has dopamine receptors. Norepinephrine and epinephrine belong to the adrenergic neurotransmitter system. The two molecules are very similar and bind to the same receptors, which are referred to as alpha and beta receptors. The biogenic amines have mixed effects. For example, dopamine receptors that are classified as D1 receptors are excitatory, whereas D2 type receptors are inhibitory. 14. The important thing to remember about neurotransmitters and signaling chemicals is that the effect is entirely dependent on the receptor. 4. Functions of neurotransmitters. An alteration in CNS function is related to abnormal impulse transmission and can result in an imbalance of a neurotransmitter. A person with an imbalance of neurotransmitters may have signs and symptoms of a CNS disorder. The medications that are used to treat CNS disorders mimic or block the neurotransmitter based on the imbalance caused by the condition. Medications are used to either stimulate or depress the effect of the neurotransmitter. For example, CNS depressants alter the brain by decreasing the excitability of neurotransmitters, blocking their receptor site, or increasing the inhibitory neurotransmitter. On the other hand, CNS stimulants increase brain activity by increasing the excitability of neurotransmitters, decreasing the inhibitory neurotransmitters, or blocking their receptor sites. Norepinephrine is often associated with the fight-or-flight response. Abnormal levels of this neurotransmitter are also associated with depression, decreased alertness and interest, along with possible palpitations, anxiety, and panic attacks. Dopamine is strongly linked to motor and cognition. This neurotransmitter influences movement and can be associated with ADHD, paranoia, and schizophrenia. Serotonin is heavily involved in many bodily processes. Abnormal levels of serotonin can affect sleep, libido, mood, and temperature regulation. Alterations of this neurotransmitter have been linked to many mental health issues such as depression, bipolar disorder, anxiety, and body disorders. GABA can act as an inhibitory neurotransmitter. GABA assists with communication in the brain, and if this neurotransmitter is low, it has been linked to issues such as anxiety, seizures, mania, and impulse control. The neurotransmitter glutamate works as an excitatory neurotransmitter and works with GABA to control other functions of the brain. Image descriptions. Figure 8.2, a mood and affect concept map. Mood and affect, the way a person feels and acts. Scope, mood spectrum, severe mania, hypomania, euthymia, melancholy. Severe melancholy, physiological process. 15. This work is a derivative of pharmacology note. Cerebral cortex, reduced blood flow and abnormal phosphorus metabolism, neurotransmitters, dopamine, norepinephrine, and serotonin, assessment, agitation, sadness, speech, energy, cognition, functional impairment, mental status assessment, suicidal ideation, must monitor for adverse effects of medication treatment such as serotonin symptoms and suicidal ideation. Management, improvement of social determinants of health, mental status exam and screening instruments, psychotherapy, pharmacotherapy, consequences, high use of medical care, potential for suicide, social and relational impacts, cognitive impacts. Figure 8.2c, somatic, autonomic, and enteric structures of the nervous system, brain, perception and processing of sensory stimuli, execution of voluntary motor responses, regulation of homeostatic mechanisms, spinal cord, initiation of reflexes from ventral horn and lateral horn gray matter, pathways for sensory and motor functions between periphery and brain, nerve, fibers of sensory and motor neurons, ganglia, reception of sensory stimuli by dorsal root and cranial ganglia, relay of visceral motor responses by autonomic ganglia, digestive tract. The enteric nervous system, located in the digestive tract, is responsible for autonomous functions and can operate independently of the brain and spinal cord. 8.3 diseases and disorders of the CNS, mood, and cognition. Now that we have reviewed basic concepts of neurotransmitters and their function, let's review common conditions and diseases related to the central nervous system, cognition, and mood, including anxiety, depression, schizophrenia, ADHD, seizures, and Parkinson's. Anxiety. Anxiety disorders are a group of conditions marked by pathological or extreme anxiety or dread. People with anxiety experience disturbances of mood, behavior, and most systems in the body, making them unable to continue with everyday activities. Many feel anxious most of the time for no apparent reason. Anxiety is different from fear. Fear is a person's response to an event or object. The psychiatric disorder of anxiety occurs when the intensity and duration of anxiety do not match the potential for harm or threat to the affected person. Anxiety can be expressed with physical symptoms or behaviorally. Signs and symptoms of anxiety: aches, pains, stomach aches, headaches, heart racing or pounding, trembling, sweating, difficulty concentrating. 1. Introduction to Mental Disorders by Khan Academy is licensed under CC BY NCSA 3. Increased agitation, crying. 5. Figure 8.3. Many clients with anxiety experience difficulty concentrating. Treatment can include non-pharmacological interventions as well as medications. Non-pharmacological interventions to decrease anxiety include relaxation techniques such as deep breathing, exercise, psychotherapy, support groups, or cognitive behavioral therapy. Anti-anxiety medications can also be used to help both verbal and nonverbal clients feel a much-needed sense of peace. Learn more about anxiety from the Canadian Mental Health Association. 5. This work is a derivative of Supporting Individuals with Intellectual Disability and Mental Illness by Sherry Melrose is licensed under CC BY 4. 6. Mayo Clinic staff, anxiety disorders. Depression. Depression is a frequent problem, affecting up to 5% of the population. To be diagnosed with depression, 5 of the following symptoms must be present during the same 2-week period and represent a change from previous functioning. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The symptoms of depression cannot be due to the effects of a substance or from bereavement. Signs and symptoms of depression: depressed mood, diminished interest, weight loss when not dieting or weight gain, insomnia or hypersomnia, agitation, fatigue or loss of energy, feeling of worthlessness, inappropriate guilt, diminished ability to concentrate, recurrent thoughts of death, suicidal ideation or suicide attempt. Treatment of depression may include medication, psychotherapy, cognitive therapy, electroconvulsive therapy, and group therapy. Clients who are depressed may not report symptoms unless specifically asked, and they may be suicidal. Using assessment techniques to gather information about the history of each client's depression, support system, specific triggering events, psychosocial assessment, and risk for harm to self or others is imperative. Each client's response to medication is unpredictable, and often medications will need to be adjusted based on reported symptoms. Learn more about depression from the Canadian Mental Health Association. Bipolar affective disorder is marked by serious mood swings. Typically, clients experience extreme highs alternating with extreme lows. See the depression section for signs and symptoms of depression. People feel normal only in the periods between the highs and lows. For some people, the cycles occur so rapidly that they hardly ever feel a sense of control over their mood swings. Signs and symptoms of a manic episode: rapid speech, hyperactivity, reduced need for sleep, flight of ideas, grandiosity, poor judgment, aggression, hostility, risky sexual behavior, neglect basic self-care, decreased impulse control. 15. Treatment for a client diagnosed with bipolar may include medication, safety initiatives during acute mania, ECT, psychotherapy, and support groups. The severity of manic and depressive episodes varies for each client. Assessing if a client is a danger to others or themselves is the priority. People with bipolar may need assistance with impulse control during times when they are in a manic state. Learn more about bipolar disorder from the Canadian Mental Health Association. Schizophrenia. Schizophrenia affects people from all walks of life and usually first appears between the ages of 15 and 14. This work is a derivative of supporting individuals. 30. Not everyone will experience the same symptoms, but many symptoms are common, such as withdrawing, hearing voices, talking to oneself, seeing things that are not there, neglecting personal hygiene, and showing low energy. Schizophrenia refers to a group of severe disabling psychiatric disorders marked by withdrawal from reality, illogical thinking, delusions, hallucinations, and flat affect. Signs and symptoms of schizophrenia. There are 3 types of symptoms related to schizophrenia: positive, negative, and cognitive. Positive symptoms. Note that in this context, the word positive is not the same as good. Rather, positive symptoms are psychotic and demonstrate how the individual has lost touch with reality. Positive symptoms include delusions, hallucinations, disorganized thinking and behavior. Delusions fall into several categories. Individuals with a persecutory delusion may believe they are being tormented, followed, tricked, or spied on. Individuals with a grandiose delusion may believe they have special powers. Individuals with a reference delusion may believe that passages in books, newspapers, television shows, song lyrics, or other environmental cues are directed toward them. In delusions of thought withdrawal or thought insertion, individuals believe others are reading their mind. Their thoughts are being transmitted to others, or outside forces are imposing their thoughts or impulses on them. Hallucinations may include hearing, seeing, smelling, tasting, or feeling as if they have been touched by things that are not there. 19. This work is a derivative of Supporting Individuals with Intellectual Disability and Mental Illness by Sherry Melrose, is licensed under CC by 4. 20. This work is a derivative. Negative symptoms. Negative symptoms are those characteristics that should be there but are lacking. Negative symptoms include apathy, lack of motivation, blunted affect, poverty of speech, anhedonia, avoidance of relationships. Keep in mind that the inability to show emotion associated with a blunted affect does not reflect an inability to feel emotion. Similarly, it is helpful to understand that withdrawing from others is a coping mechanism for an individual with schizophrenia and not a rejection of those who initiate contact. Cognitive. Cognitive symptoms are a change in thought pattern and include poor decision-making, loss of memory, distracted, difficulty focusing. Treatment for a client diagnosed with schizophrenia may include medications to control positive and/or negative signs and symptoms and non-pharmacological interventions such as limit setting, therapeutic communication, ECT, and psychotherapy. Key assessments for a client with schizophrenia include examination for hallucinations and delusions, use of additional substances, safety, their support system, and a medication review with a focus on compliance with their therapeutic regimen. 23. Learn more about schizophrenia from the Canadian Mental Health Association. 22. This work is a derivative of Supporting Individuals with Intellectual Disability and Mental Illness by Sherry Melrose, is licensed under CC by 4. 23. This work is a derivative of Principles of Pharmacology by LibreText, licensed under CC by NCSA 4. 24. Varkarolis E.M. Essentials of Psychiatric Mental Health Nursing, a Communication Approach to Evidence-Based Care. pp. 255 to 324. Elsevier, 25. Mayo Clinic Staff, Schizophrenia. DRC 20,354,449. Attention Deficit Hyperactivity Disorder. Attention Deficit Hyperactivity Disorder is characterized by hyperactivity, lack of impulse control, and/or lack of attention that interferes with how a person functions. ADHD is often diagnosed during childhood, but signs and symptoms can last through adulthood. Signs and symptoms of ADHD: hyperactivity, inability to concentrate, difficulty with self-control, lack of emotional control. A child with ADHD may have difficulty sitting still and focusing at school or have emotional outbursts. These behaviors often impact their life. Medication, psychotherapy, behavior management, and family support all play a large part in helping an individual with ADHD. Additional resources for parents are also helpful. 26. Right Brain Dominant, JPG by Elisa Riva, is licensed under CC0. 27. Mayo Clinic Staff, Attention Deficit Hyperactivity Disorder in Children. Figure 8.3b clients with ADHD may have difficulty in focusing on details. Learn more about ADHD from Canada's Centre for Addiction and Mental Health. Seizures. The official definition of a seizure is a transient occurrence of signs and/or symptoms due to an abnormal, excessive, or synchronous neuronal activity in the brain. This means that during a seizure, large numbers of brain cells are activated abnormally at the same time. It is like an electrical storm in the brain. They may alter consciousness and produce abnormal motor activity. There are different classifications of seizures based on severity of symptoms. Signs and symptoms of seizures. Motor symptoms: jerking, muscles becoming limp or weak, tense or rigid muscles, brief muscle twitching, epileptic spasms. Non-motor symptoms: changes in sensation, emotions, thinking, or autonomic functions. Lack of movement. Classification of seizures. Seizures are classified in many ways, beginning with whether they're partial or generalized seizures. Partial seizures. Partial seizures have focal onset on one side of the brain. They are further classified into simple, complex, or secondarily generalized. Simple partial seizures are most common. They may also affect sensory and autonomic systems. Complex partial seizures include impairment of consciousness, with or without motor activity or other signs. Simple or complex partial seizures may become secondarily generalized, producing a tonic-clonic seizure. Generalized seizures. Generalized seizures have bilateral onset on both sides of the brain and are typified by petit mal seizures, which can be recognized by clinical characteristics as well as interictal EEG abnormalities. 30, 31, 32, 33. Status epilepticus. Status epilepticus is a state of repeated or continuous seizures. It is often defined operationally as a single seizure, lasting more than 20 minutes, or repeated seizures without recovery of consciousness. Prolonged status epilepticus leads to irreversible brain injury and has a very high rate of mortality. The goal of therapy should be to achieve control of a seizure within 60 minutes or less. Pharmacological treatment of seizures is very successful in the majority of cases, but it requires accurate diagnosis and classification of seizures. Medication management of seizures may include CNS depressants, benzodiazepines or barbiturates, or anticonvulsants such as phenytoin. Parkinson's disease. Parkinson's disease is a progressive disease of the nervous system that impairs one's ability to move. The typical onset for Parkinson's disease is middle to later stages of life. This disease worsens over time and has no cure. The cause of this disease is unknown, but it is known that it is characterized by a loss of dopaminergic neurons. Signs and symptoms of Parkinson's disease: tremor at rest, bradykinesia, muscle rigidity, postural instability, gait disturbance, dystonia, ophthalmoplegia, active mood disorders. See Figure 8.3c for a typical posture associated with Parkinson's disease. Treatment for a client with Parkinson's disease often includes medication to increase dopamine in the brain to slow the progression of the disease. Figure 8.3c, the typical stooping posture associated with Parkinson's disease. Potential new treatment of proteins in Alzheimer's and Parkinson's disease. The underlying cause of some neurodegenerative diseases, such as Alzheimer's and Parkinson's, appears to be related to proteins, specifically to proteins behaving badly. One of the strongest theories of what causes Alzheimer's disease is based on the accumulation of beta amyloid plaques, dense conglomerations of a protein that is not functioning correctly. Parkinson's disease is linked to an increase in a protein known as alpha-synuclein that is toxic to the cells of the substantia nigra nucleus in the midbrain. For proteins to function correctly, they are dependent on their three-dimensional shape. The linear sequence of amino acids folds into a three-dimensional shape that is based on the interactions between and among those amino acids. When the folding is disturbed and proteins take on a different shape, they stop functioning correctly. But the disease is not necessarily the result of functional loss of these proteins. Rather, these altered proteins start to accumulate and may become toxic. For example, in Alzheimer's, the hallmark of the disease is the accumulation of these amyloid plaques in the cerebral cortex. The term coined to describe this sort of disease is proteopathy, and it includes other diseases. Creutzfeldt-Jakob disease, the human variant of the disease known as mad cow disease, also involves the accumulation of amyloid plaques, similar to Alzheimer's. Diseases of other organ systems can fall into this group as well, such as cystic fibrosis or type 2 diabetes. Recognizing the relationship between these diseases has suggested new therapeutic possibilities, interfering with the accumulation of the proteins and, possibly as early as their original production within the cell, may unlock new ways to alleviate these devastating diseases. 8.4 Clinical reasoning and decision-making for CNS regulation, mood, and cognition. Clinical reasoning is a way that nurses think and process our knowledge, including what we have read or learned in the past, and apply it to the current practice context of what we are seeing right now. Nurses make decisions all the time, but making decisions requires a complex thinking process. There are many tools that are useful and found online that can support your thinking through to clinical judgments. This book uses the nursing process and clinical judgment language to help you understand the application of medication to your clinical practice. Now that we have reviewed various CNS disorders and the anatomy and physiology underlying them, let's review the importance of the nursing process and clinical judgment in guiding the nurse who administers CNS medication to treat these disorders. Assessment. Although there are numerous details to consider when administering medications, it is always important to first think about what you are giving and why. First, let's think of why. Recognizing cues. When thinking about administering CNS medication, there are many things to consider. Each medication is given for a specific purpose for your client, and it is your job as a nurse to assess your clients and collect important data before safely administering medication. As a nurse, not only will you perform the skill of administering medications, but you will be expected to think critically about your client and the safety of any medication at any particular time. A nursing assessment completed prior to administering CNS medication will likely look different than an assessment for other types of medication, because most of the assessments associated with CNS medication are done by collecting subjective data rather than objective data. For example, prior to administering a cardiac medication, a nurse will obtain objective data such as blood pressure and an apical heart rate. However, prior to administering CNS medication, a nurse will use therapeutic communication to ask questions to gather subjective data about how the client is feeling. After reviewing the possible diseases connecting with the CNS system, you probably notice that there is usually an associated imbalance of a neurotransmitter. As a nurse, you cannot directly measure a neurotransmitter to determine the effects of the medication, but you can ask questions to determine how your client is feeling emotionally and perceiving the world, conditions which are influenced by neurotransmitter levels. An example of a nurse using therapeutic communication to perform subjective assessment is asking a question such as, "Tell me more about how you are feeling today." The nurse may also use general survey techniques such as simply observing the client to assess for cues of behavior. Examples of data collected by a general survey could be assessing the client's mood, hygiene, appearance, or movement. Interventions. Next, plan and take action. With the administration of any medications, it is important to always perform the 5 rights and to check for allergies prior to administration. It is important to anticipate any common side effects and the expected outcome of the medication. When you administer CNS medication, it is key to perform assessments before administering medication because many clients may have changing behaviors and habits that influence the way they think and feel about taking their medication. Additionally, some medications require an assessment of lab values before administration. Many CNS medications may also have cumulative effects when used in conjunction with other medications, so careful assessment of the impact of the medications on one another is needed. Evaluation. Finally, evaluate the outcomes of your action. It is important to always evaluate the client's response to a medication. Some CNS medications will take weeks to become therapeutic for the client. It is key to teach the client about when the medication is expected to produce an effect. Nurses should assess for mood, behavior, and movement improvement. If medications are effective, then clients should report fewer negative thoughts, worry, and symptomatic behaviors, as well as demonstrate fewer abnormal movements. Nurses also need to continually monitor for adverse effects, some of which can be life-threatening and require prompt notification to the prescribing provider. Additionally, if symptoms are not improving or the client's condition is worsening, the nurse should promptly notify the prescribing provider for further orders. For example, a symptom and/or adverse reaction of several CNS medications is increased thoughts of suicide. If a client is experiencing thoughts of suicide, immediate assistance should be obtained to keep them safe. For more information about suicide prevention, refer to the Canadian Association for Suicide Prevention site. Now that we have reviewed CNS basics and how to use the nursing process related to CNS medications, we will take a closer look at specific classes of CNS medications. We will review classes and specific administration considerations, therapeutic effects, adverse side effects, and teaching needed for each class of medications. 8.5 CNS depressants. CNS depressants can slow brain activity, making them useful for conditions related to seizures and anxiety. Barbiturates and benzodiazepines are examples of CNS depressants. Barbiturates. Phenobarbital is an example of a barbiturate primarily used as a sedative and to treat seizure disorders. In high doses, it can be used to induce anesthesia, and overdosage can cause death. In the 1960s and 1970s, barbiturates were used to treat anxiety and insomnia, but are no longer used for these purposes due to their serious adverse effects. Barbiturates are controlled substances under the Pharmacy Operations and Drug Scheduling Act. However, the misuse of barbiturates continues to occur with street use as a downer to counteract the effect of cocaine and methamphetamine. Mechanism of action. Barbiturates produce sedation and drowsiness by altering cerebellar function and depressing the actions of the brain and sensory cortex. Indications for use: primarily used as an anticonvulsant, also used as a sedative, and may also be used as a pre-anesthetic agent. Nursing considerations across the lifespan. Do not use it for children less than 1 month of age. Barbiturates may harm the fetus during pregnancy. Avoid use in geriatric clients. Adverse side effects. Clients may experience CNS depression, suicidal thoughts or behaviors, GI disturbances, rashes, or some blood disorders that can be fatal. The concomitant use of alcohol or other CNS depressants may produce additive CNS depressant effects that can cause death. Barbiturates can be habit-forming. Contraindicated for use in clients with severe renal and hepatic disorders, severe respiratory depression, dyspnea or airway obstruction, and porphyria. Client teaching and education. The client should be advised to take the prescribed medication as directed. Clients who undergo prolonged therapy should not discontinue treatment abruptly, as this may cause the onset of seizure activity. These medications may cause drowsiness and should not be taken with alcohol or other CNS depressants. Female clients using oral contraceptives should also use non-hormonal based contraceptives during therapy involving barbiturate use. Overdosage. The onset of symptoms following a toxic oral exposure to phenobarbital may not occur until several hours following ingestion. If an overdose occurs, consult with the Poison Information Center. Phenobarbital medication card. Now, let's take a closer look at the medication grid for phenobarbital in Table 8.5a. Medication cards like this are intended to assist students to learn key points about each medication. Because information about medication is constantly changing, nurses should always consult evidence-based resources to review current recommendations before administering specific medication. Basic information related to each class of medication is outlined below. Prototype or generic medication examples are also hyperlinked to a free resource at DailyMed. On the homepage, enter the drug name in the search bar to read more about the medication. Mechanism: alters cerebellar function and depresses actions of the brain and sensory cortex. 3. This work is a derivative of DailyMed by U.S. National Library of Medicine in the public domain. 5. RNpedia. 6. OpenMD.com at www.openmd.com. 7. U-Central from Unbound Medicine. Therapeutic effects: reduction in seizures, sedation, administration. Orally IM or fourth taper dose do not stop abruptly when sedation is needed. Seizures. Contraindications: severe renal and hepatic disorders, severe respiratory depression, dyspnea, or airway obstruction, porphyria. Not for children under 1 month. Not for use in pregnancy. Avoid in geriatric clients. Side effects: CNS depression, overdosage can cause death, may cause suicidal thoughts or behavior, respiratory depression. GI, nausea and vomiting. Nursing considerations: take as directed, may be habit forming, do not take with other CNS, depressants or alcohol. Benzodiazepines. Lorazepam, a benzodiazepine with anti-anxiety, sedative, and anticonvulsant effects, is available for oral, intramuscular, or intravenous routes of administration. Benzodiazepines are controlled substances because they have a potential for abuse and may lead to dependence. Mechanism of action: benzodiazepines bind to specific GABA receptors to potentiate the effects of GABA. Indications for use: benzodiazepines are used for sedation, anti-anxiety, and anticonvulsant effects. Lorazepam injection is indicated for the treatment of status epilepticus. It may also be used in adult clients for pre-anesthetic medication to produce sedation, relieve anxiety, and decrease the ability to recall events related to the day of surgery. Oral lorazepam is used to treat anxiety disorders. Nursing considerations across the lifespan: benzodiazepines may cause fetal harm when administered to pregnant women. Children and the elderly are more likely to experience paradoxical reactions to benzodiazepines, such as tremors, agitation, or visual hallucinations. Elderly or debilitated clients may be more susceptible to the sedative and respiratory depressive effects of lorazepam. Therefore, these clients should be monitored frequently and have their dosage adjusted carefully according to the client's response. The initial dosage should not exceed 2 milligrams. Dosage for clients with severe hepatic insufficiency should be adjusted carefully according to client response. Adverse side effects: a black box warning states that concomitant use of benzodiazepines and opioids may result in profound sedation, respiratory depression, coma, and death. The most important risk associated with the intravenous use of lorazepam injection is respiratory depression. Accordingly, airway patency must be assured and respiration monitored closely. Ventilatory support should be given as required. The additive central nervous system effects of other drugs, such as phenothiazines, narcotic analgesics, barbiturates, antidepressants, scopolamine, and monoamine oxidase inhibitors, should be considered when these other drugs are used concomitantly with, or during the period of recovery from, lorazepam injection. Sedation, drowsiness, respiratory depression, hypotension, and unsteadiness may occur with oral dosages as well. The use of benzodiazepines may lead to physical and psychological dependence. Abrupt termination of treatment may be accompanied by withdrawal symptoms. Benzodiazepines should be prescribed for short periods only. Treatment period should not be extended without reevaluation of the need for continued therapy. Overdosage. Overdosage of benzodiazepines is usually manifested by varying degrees of central nervous system depression, ranging from drowsiness to coma. Treatment of overdosage is mainly supportive until the drug is eliminated from the body. Vital signs and fluid balance should be carefully monitored in conjunction with close observation of the client. An adequate airway should be maintained and assisted respiration used as needed. The benzodiazepine antagonist flumazenil may be used for hospitalized clients in the management of benzodiazepine overdose. There is a risk of seizure in association with flumazenil treatment, particularly in long-term benzodiazepine users. If an overdose occurs, consult with a poison information center. Client teaching and education. Clients who receive lorazepam should be cautioned that driving a motor vehicle, operating machinery, or engaging in hazardous or other activities requiring attention and coordination should be delayed for 24 to 48 hours following administration or until the effects of the drug, such as drowsiness, have subsided. Clients should be advised that if they get out of bed unassisted within 8 hours of receiving lorazepam, they risk falling and potentially sustaining injury. Alcoholic beverages should not be consumed for at least 24 to 48 hours after receiving lorazepam injectable due to the additive effects on central nervous system depression seen with benzodiazepines in general. Elderly clients should be instructed that lorazepam injection may make them very sleepy for a period longer than 6 to 8 hours following surgery. Lorazepam medication card. Now let's take a closer look at the medication card for lorazepam. Because information about medication is constantly changing, nurses should always consult evidence-based resources to review current recommendations before administering specific medication. Reduced seizure activity, administration, SLPO, fourth, use cautiously in elderly, and consider smaller dose for liver dysfunction, indications, to relieve anxiety, reduce seizure activity, or as a pre-anesthetic. Contraindications: severe hepatic impairment, respiratory depression, acute narrow-angle glaucoma, pregnancy and lactation, not for children under 12, side effects, oversedation and drowsiness, potentially fatal respiratory depression. Overdosage can cause coma and death, safety, unsteadiness, and fall risk. Concomitant use of benzodiazepines and opioids may result in profound sedation, respiratory depression, coma, and death. Flumazenil used for overdose. Nursing considerations: monitor for falls risk. Take as prescribed. Do not stop taking drug without consulting healthcare provider. Avoid operating motor vehicle or heavy machinery. Do not consume alcohol. Clinical reasoning and decision making activity 8.5. A client who has been experiencing panic attacks is prescribed lorazepam. Upon further discussion with the client, the nurse discovers that the client is planning to go on a cruise with her husband next week and plans to use a scopolamine patch to control nausea. The client states, "I can't wait to relax on the cruise ship and have a margarita as we leave port." What important client education should the nurse provide to the client about the new prescription for lorazepam? Note, answers to the critical thinking activities can be found in the answer key sections at the end of the book. 8.6 CNS stimulants. CNS stimulants are clinically used for the treatment of attention deficit disorders to help calm hyperkinetic children and help them focus on one activity for a longer period. The majority of CNS stimulants are controlled substances. Methylphenidate. Methylphenidate is an example of a CNS stimulant that is often used to treat ADHD. Mechanism of action. Methylphenidate stimulates the brain and acts similar to amphetamines. It is thought to block the reuptake of norepinephrine and dopamine into the presynaptic neuron. Indications for use. Methylphenidate is used for ADHD. Nursing considerations across the lifespan. Methylphenidate is typically prescribed to clients over the age of 6. It should be avoided in clients with known structural cardiac abnormalities, cardiomyopathy, serious heart rhythm arrhythmias, or coronary artery disease. Blood pressure and heart rate should be monitored in all clients. CNS stimulants have been associated with weight loss and slowing of growth rate in pediatric clients. It increases the risk of peripheral vasculopathy, such as Raynaud's phenomenon, with signs and symptoms of fingers or toes feeling numb, cool, painful, and/or changing color from pale to blue to red. Methylphenidate is contraindicated in clients using a monoamine oxidase inhibitor or use of an MAOI within the preceding 14 days. If paradoxical worsening of symptoms or other adverse reactions occur, the dosage should be reduced or, if necessary, discontinued. Administer methylphenidate hydrochloride extended-release capsules orally once daily in the morning. Extended-release capsules should not be crushed, chewed, or divided. Monitor for signs of misuse and dependence while in therapy. Adverse side effects. Stimulant treatment in pediatric clients with structural cardiac abnormalities or other serious heart problems. Sudden death, stroke, and myocardial infarction have also been reported in adults with CN stimulant treatment at recommended doses. Methylphenidate may cause increased blood pressure and increased heart rate. Use of stimulants may cause psychotic or manic symptoms in clients with no prior history and may cause priapism. The most common adverse reactions were headache, insomnia, upper abdominal pain, decreased appetite, and anorexia. Alcohol should be avoided because it may cause a rapid release of the drug in extended release formulations. Overdose. If an overdose occurs, consult with a poison information center. Client teaching and education. There are several important topics to address with clients and/or parents of minor children. Misuse and dependence. Advise clients that methylphenidate is a controlled substance, and it can be misused and lead to dependence. Instruct clients that they should not give methylphenidate to anyone else. Advise clients to store methylphenidate in a safe, preferably locked, place to prevent misuse. Advise clients to comply with laws and regulations on drug disposal. Advise clients to dispose of remaining, unused, or expired methylphenidate through a medicine take-back program if available. Serious cardiovascular risks. Advise clients that there is a serious potential cardiovascular risk, including sudden death, myocardial infarction, stroke, and hypertension. Instruct clients to contact a healthcare provider immediately if they develop symptoms such as exertional chest pain or unexplained syncope. Blood pressure and heart rate increases. Instruct clients that methylphenidate hydrochloride extended-release capsules can cause elevations of their blood pressure and pulse rate. Psychiatric risks. Advise clients that methylphenidate can cause psychotic or manic symptoms, even in clients without prior history of psychotic symptoms or mania. Priapism. Advise clients of the possibility of painful or prolonged penile erections and to seek immediate medical attention if this occurs. Circulation problems in fingers and toes. Instruct clients beginning treatment with methylphenidate about the risk of peripheral vasculopathy and associated signs and symptoms. Fingers or toes may feel numb, cool, painful, and/or may change color from pale to blue to red. Instruct clients to report to their physician any new numbness, pain, skin color change, or sensitivity to temperature in fingers or toes, or any signs of unexplained wounds appearing on fingers or toes. Suppression of growth. Advise parents that methylphenidate may cause slowing of growth and weight loss. Alcohol effect. Advise clients to avoid alcohol while taking extended-release capsules. Methylphenidate medication card. Now let's take a closer look at the medication card for methylphenidate. Because information about medication is constantly changing, nurses should always consult evidence-based resources to review current recommendations before administering specific medication. Increase mental focus and attention. Administration. Administer in the morning. Do not crush or chew. Safe for use over the age of 6. Avoid with CVS disease. Indications. Attention deficit disorders, contraindications, use of an MAOI within 14 days, cardiac disease, pregnancy, and lactation. Side effects. Serious side effects, cardiac and perfusion. Priapism, mania, psychosis. Common side effects, headache, insomnia, upper abdominal pain, decreased appetite, and anorexia. Gynecomastia, may slow growth in pediatric clients. Safety, high misuse potential. Monitor BP and HR. Monitor growth WT in children. Nursing considerations, controlled substance. 2. This work is a derivative of Daily Med by U.S. National Library of Medicine in the public domain. 3. This work is a derivative of Daily Med by U.S. National Library of Medicine in the public domain. Parent teaching. Clients should avoid alcohol. Monitor for misuse. Clinical reasoning and decision-making activity 8.6. A 12-year-old male child has been diagnosed with ADHD after his parents and teachers became concerned with his inability to concentrate and his poor impulse control in the classroom. The physician has prescribed methylphenidate. What topics should the nurse reinforce while educating the child and his parents about this medication? Note, answers to the critical thinking activities can be found in the answer key sections at the end of the book. 8.7 Antidepressants. Antidepressants are used to treat depression and other mental health disorders, as well as other medical conditions such as migraine headaches, chronic pain, and premenstrual syndrome. Antidepressants increase levels of neurotransmitters in the CNS, including serotonin, dopamine, and norepinephrine. Treatment is based on the belief that alterations in the levels of these neurotransmitters are responsible for causing depression. This module will discuss 4 classes of antidepressants: tricyclic antidepressants, selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, and monoamine oxidase inhibitors. These medications are compared in Table 8.7. TCAs and MAOIs are referred to as first-generation antidepressants because they were first marketed in the 1950s. SSRIs, SNRIs, and other miscellaneous medications such as bupropion are called second-generation antidepressants and are popular because of fewer side effects like sedation, hypotension, anticholinergic effects, or cardiotoxicity. Safety warnings are in place for all classes of antidepressants used with children, adolescents, and young adults for a higher risk of suicide. All clients receiving antidepressants should be monitored for signs of worsening depression or changing behavior, especially when the medication is started or dosages are changed. For more information on different types of antidepressants, watch this video. One or more interactive elements has been excluded from this version of the text. You can view them online here. Tricyclic antidepressants. Tricyclic antidepressants were one of the original first-generation antidepressants. Due to the popularity of SSRIs and SNRIs, TCAs are now more commonly used to treat neuropathic pain and insomnia. Mechanism of action. TCAs tend to have sedative and anticholinergic effects. They act by inhibiting presynaptic reuptake of NE and 5-HT into nerves. The choice of TCA depends on individual response and tolerance to the drug. Indications for use. TCAs are used to treat depression, chronic neuropathic pain, and insomnia. Nursing considerations across the lifespan. TCAs are often administered at bedtime due to sedating effects and are contraindicated with MAOIs. Geriatric clients are particularly sensitive to the anticholinergic side effects of tricyclic antidepressants. Peripheral anticholinergic effects include tachycardia, urinary retention, constipation, dry mouth, blurred vision, and exacerbation of narrow-angle glaucoma. Central nervous system anticholinergic effects include cognitive impairment, psychomotor slowing, confusion, sedation, and delirium. Elderly clients taking amitriptyline may be at increased risk for falls. Elderly clients should be started on low doses of amitriptyline and observed closely. After prolonged administration, abrupt cessation of treatment may produce nausea, headache, and malaise. The dose should be gradually tapered, but transient symptoms may still occur. TCAS should not be used in children and those who are pregnant or lactating. Adverse side effects. Adverse effects of TCAs are a result of their blockade effects on various receptors, often resulting in anticholinergic adverse effects such as constipation, urinary retention, and drowsiness. Blockage of adrenergic and dopaminergic receptors can cause cardiac conduction disturbances and hypotension. Histaminergic blockage can cause sedation, and serotonergic blockade can alter the seizure threshold and cause sexual dysfunction. Black box warnings are in place for all classes of antidepressants used with children, adolescents, and young adults for higher risk of suicide. Clients receiving antidepressants should be monitored for signs of worsening depression or changing behavior, especially when the medication is started or dosages are changed. TCAs are contraindicated as follows: myocardial infarction, concurrent use of MAOIs, pregnancy, lactation, pre-existing cardiovascular disorders, angle closure glaucoma, urinary retention, prostate hypertrophy, GI or GU surgery. History of seizures. Hepatorenal diseases. There are also several drug interactions such as cimetidine, fluoxetine, ranitidine, increased therapeutic and adverse effects of TCAs. Usage with oral anticoagulants can increase serum levels of anticoagulants and increase the risk of bleeding. TCAs should not be used concurrently with MAOIs, which increases the risk for a severe hyperpyretic crisis. 3. Overdosage. Death may occur from overdosage with this class of drugs. Multiple drug ingestion is common in deliberate tricyclic antidepressant overdose. If an overdose occurs, consult with a poison information center. Client teaching and education, due to the increased risk of suicidality with antidepressants, clients and their family members or caregivers should be instructed to immediately report any sudden changes in mood, behaviors, thoughts, or feelings. The potential side effects discussed above should be reviewed. 4. Table 8.7 provides a closer look at this medication and compares TCAs with other classifications of antidepressants. Selective serotonin reuptake inhibitor. Selective serotonin reuptake inhibitors are second-generation antidepressants and have fewer side effects than TCAs and MAOIs. Fluoxetine and citalopram are commonly used SSRIs. Mechanism of action. SSRIs inhibit the reuptake of serotonin. Indications for use. SSRIs are primarily used to treat depression, but are also used to treat obsessive compulsive disorder, bulimia, panic disorder, post-traumatic stress disorder, other forms of anxiety, premenstrual syndrome, and migraines. Nursing considerations across the lifespan. The onset of fluoxetine's antidepressant effect develops slowly for up to 12 weeks. Use caution in clients who are taking other CNS medications or who have liver dysfunction. This drug is contraindicated with MAOIs. Monitor for increased suicide ideation in all populations, as well as for the development of serotonin syndrome. Clients should avoid grapefruit juice due to its effect on the CYP3A4 enzyme that affects the bioavailability of the medication. Adverse side effects. Black box warnings are in place for all classes of antidepressants used with children, adolescents, and young adults for higher risk of suicide. Clients receiving antidepressants should be monitored for signs of worsening depression or changing behavior, especially when the medication is started or dosages are changed. The development of a potentially life-threatening serotonin syndrome or neuroleptic malignant syndrome-like reactions has been reported with SNRIs and SSRIs, particularly with concomitant use of serotonergic drugs that impair the metabolism of serotonin, or with antipsychotics or other dopamine antagonists. Symptoms of serotonin syndrome may include mental status changes, autonomic instability, neuromuscular aberrations, and/or gastrointestinal symptoms. Serotonin syndrome, in its most severe form, can resemble neuroleptic malignant syndrome, which includes hyperthermia, muscle rigidity, autonomic instability with possible rapid fluctuation of vital signs, and mental status changes. Clients should be monitored for the emergence of serotonin syndrome or NMS-like signs and symptoms. Other side effects include rash, mania, seizures, decreased appetite and weight, increased bleeding, associated with the concomitant use of fluoxetine and NSAIDs, aspirin, warfarin, or other drugs that affect coagulation, hyponatremia, anxiety, and insomnia. Abrupt discontinuation may cause several adverse effects, so a gradual reduction in the dose rather than abrupt cessation is recommended whenever possible. 8. Client teaching and education. Clients should be careful to take medications as directed. Abrupt discontinuation may cause anxiety, insomnia, and increased nervousness. Additionally, orthostatic blood pressure changes are common during medication therapy. Clients may also be increasingly drowsy or exhibit some confusion. Use of SSRI medications with alcohol or other CNS depressant drugs should be avoided. Clients, family, and caregivers should monitor clients carefully for suicidality. Other side effects include possible decreased libido, urinary retention, constipation, and increased photosensitivity. Table 8.7 provides a closer look at this medication and compares SSRIs with other classifications of antidepressants. A 32-year-old female visits the nurse practitioner with concerns about feeling tired all the time, having difficulty concentrating, problems sleeping, and just generally feeling down. The nurse practitioner prescribed fluoxetine. The client tells the nurse, "One of my friends told me I have to be careful or I might get serotonin syndrome if I take medication." 1. What places a client at risk for serotonin syndrome? And what symptoms should the nurse teach the client about this condition? 2. The nurse knows that anyone starting an antidepressant is at risk for suicidal thoughts. How should the nurse therapeutically discuss this potential adverse effect with the client? 3. What potential common side effects should the nurse discuss with the client? The client states, "I can't wait to feel better again. How soon will this medication work?" 4. What is the nurse's best response? Serotonin norepinephrine reuptake inhibitor. Venlafaxine is an example of a serotonin norepinephrine reuptake inhibitor. Mechanism of action. Venlafaxine inhibits the reuptake of serotonin and norepinephrine with weak inhibition of dopamine reuptake. Indications for use. SNRIs are indicated for the treatment of a major depressive disorder. Nursing considerations across the lifespan. SNRIs are contraindicated with MAOIs or within 14 days of use of an MAOI. Dosage adjustment is required for use in clients with renal and/or liver disease. Elderly clients are at greater risk for developing hyponatremia. Use with caution with other serotonin medications. Adverse side effects. Black box warnings are in place for all classes of antidepressants used with children, adolescents, and young adults for higher risk of suicide. Clients receiving antidepressants should be monitored for signs of worsening depression or changing behavior, especially when the medication is started or dosages are changed. SNRI medication may cause a sustained increase in blood pressure. Other side effects include serotonin syndrome, insomnia, anxiety, decreased appetite, weight loss, mania, hyponatremia, increased bleeding, elevated serum cholesterol, somnolence, and nausea. 11. Client teaching and education. Clients should be careful to take medications as directed. The dose should be tapered prior to discontinuation. Clients may also be increasingly drowsy or dizzy. Use of SNRI medications with alcohol or other CNS depressant drugs should be avoided. Clients, family, and caregivers should monitor clients carefully for suicidality. Table 8.7 provides a closer look at this medication and compares SSRIs with other classifications of antidepressants. Monoamine oxidase inhibitors. Monoamine oxidase inhibitors are first-generation antidepressants. A significant disadvantage to MAOIs is their potential to cause a hypertensive crisis when taken with stimulant medications or foods containing tyramine. Mechanism of action. The mechanism of action of MAOIs is not fully understood, but is presumed to be linked to the potentiation of monoamine neurotransmitter activity in the central nervous system, resulting from its inhibition of the enzyme monoamine oxidase. MAO inactivates norepinephrine, dopamine, epinephrine, and serotonin. By inhibiting MAO, the levels of these transmitters rise, thus creating antidepressive effects. Indications for use. MAOIs are indicated for the treatment of major depressive disorder in adult clients who have not responded adequately to other antidepressants. Nursing considerations across the lifespan. Serious interactions with several medications, as well as foods and beverages containing tyramine, have been reported. Check drug labeling before administering. Safety has not been established with the pediatric population. The elderly population is at increased risk for postural hypotension and serious adverse effects. Misuse and dependence have been reported. Withdrawal effects can continue for several weeks after discontinuation. Adverse side effects. Black box warnings are in place for all classes of antidepressants used with children, adolescents, and young adults for higher risk of suicide. Clients receiving antidepressants should be monitored for signs of worsening depression or changing behavior, especially when the medication is started or dosages are changed. Use with caution due to the risks of hypertensive crisis, serotonin syndrome, and increased suicidality. Hypertensive crisis is defined by severe hypertension with evidence of organ dysfunction. Symptoms may include occipital headache, palpitations, neck stiffness or soreness, nausea or vomiting, sweating, dilated pupils, photophobia, shortness of breath, or confusion. Either tachycardia or bradycardia may be present and may be associated with constricting chest pain. Seizures may also occur. Intracranial bleeding, sometimes fatal, has been reported in association with the increase in blood pressure. See more information about serotonin syndrome in the SSRI section. Other potential side effects include mania, orthostatic hypotension, hepatotoxicity, seizures, hypoglycemia in diabetic clients, decreased appetite and weight loss, dizziness, headache, drowsiness, and restlessness. Clients should be advised it may impair their ability to operate machinery or drive. MAOIs should be discontinued if hepatotoxicity occurs. Client teaching and education. Clients should be careful to take medications as directed. It may take up to 4 weeks to see the effects of the drug. They should avoid abrupt cessation of therapy to avoid withdrawal symptoms. Clients should avoid alcohol, other CNS depressants, and tyramine-containing products for 2 weeks after therapy is discontinued. Clients should be advised regarding the signs of hypertensive crisis and to immediately report headache, chest, or throat tightness, and palpitations to the provider. Now let's take a closer look at a medication grid that compares these classifications of antidepressants. 1617. Medication cards like this are intended to assist students to learn key points about each medication. Because information about medication is constantly changing, nurses should always consult evidence-based resources to review current recommendations before administering specific medication. Basic information related to each class of medication is outlined below. Prototype or generic medication examples are also hyperlinked to a free resource at DailyMed. On the homepage, enter the drug name in the search bar to read more about the medication. 14. This work is a derivative of DailyMed by U.S. National Library of Medicine in the public domain. This work is a derivative of DailyMed by U.S. National Library of Medicine in the public domain. Table 8.7 comparing types of antidepressants. 18,192,021. 18. This work is a derivative of DailyMed by U.S. National Library of Medicine in the public domain. 8.8 Anti-mania. Mood stabilizers are used to treat bipolar affective disorder. Lithium was the first medication used to treat this disorder and is sometimes referred to as an anti-mania drug because it can help control the mania that occurs in bipolar disorder. Lithium must be closely monitored with a narrow therapeutic range. Lithium. Mechanism of action. Lithium alters sodium transport in nerve and muscle cells and causes a shift toward intraneuronal metabolism of catecholamines, but the specific biochemical mechanism of lithium action in mania is unknown. Indications for use. Lithium is indicated in the treatment of manic episodes of bipolar disorder and as a maintenance treatment for individuals with a diagnosis of bipolar disorder. Nursing considerations across the lifespan. Lithium must be closely monitored with a narrow therapeutic serum range of 0.6 to 1.2 mol/L. 3. Serum sodium levels should also be monitored for potential hyponatremia. The drug is contraindicated in renal or cardiovascular disease, severe dehydration or sodium depletion, and to clients receiving diuretics because the risk of lithium toxicity is very high in such clients. Lithium can cause fetal harm in pregnant women. Safety has not been established for children under 12 and is not recommended. 1. MC-Quistion L, Voljoin DiMaggio K, Winton M, and Jaeger J. Pharmacology, a patient-centered nursing process approach. pp. 227. Given to a client experiencing a manic episode, lithium may produce a normalization of symptomatology within 1 to 3 weeks. Adverse side effects. Black box warning. Lithium toxicity is closely related to serum lithium levels and can occur at doses close to therapeutic levels at 1.5 meters EQL. Facilities for prompt and accurate serum lithium determinations should be available before initiating therapy. Lithium can cause abnormal electrocardiographic findings and risk of sudden death. Clients should be advised to seek immediate emergency assistance if they experience fainting, lightheadedness, abnormal heartbeats, or shortness of breath. Signs of early lithium toxicity include diarrhea, vomiting, drowsiness, muscular weakness, and lack of coordination. At higher levels, giddiness, ataxia, blurred vision, tinnitus, and a large output of dilute urine may be seen. No specific antidote for lithium poisoning is known. Treatment focuses on the elimination of the medication. Fine hand tremor, polyuria, and mild thirst may also persist throughout treatment. Client teaching and education. Clients should take medication as directed. It is important to note that antimanic drugs may increase dizziness and drowsiness. Additionally, if individuals have low sodium levels, it may predispose the client to toxicity. Clients should also be advised that weight gain may occur. Lithium medication card. Now let's take a closer look at the medication grid for lithium. Medication cards like this are intended to assist students to learn key points about each medication. Because information about medication is constantly changing, nurses should always consult evidence-based resources to review current recommendations before administering specific medication. Basic information related to each class of medication is outlined below. Prototype or generic medication examples are also hyperlinked to a free resource at DailyMed. On the homepage, enter the drug name in the search bar to read more about the medication. 9. MC-Quistion L, Voljoin DiMaggio K, Winton M, and Jaeger J. Pharmacology, a patient-centered nursing process approach. pp. 227 to 305. Elsevier, medication card 8.8.1, lithium, generic name, lithium. Prototype brand name, Lithane, Carbot-Lith. Mechanism alters sodium transport in nerve and muscle cells to shift toward intraneuronal metabolism of catecholamines. Specific biochemical mechanism in mania is unknown. Therapeutic effects: reduced symptoms of manic episode, reduced frequency and intensity of manic episodes. Administration: monitor for signs of lithium toxicity. Monitor serum lithium and sodium levels. Treatment of manic episodes of bipolar disorder. Maintenance for individuals with a bipolar disorder. Contraindications: renal and CVS disease, dehydration and use of diuretics, children under 12, pregnancy and lactation. Side effects: lithium toxicity, hyponatremia, tremor, cardiac arrhythmia, polyuria, thirst, dizzy and drowsy, weight gain. Safety: signs of lithium toxicity requires emergency assistance. Nursing considerations: take as directed. When given during a manic episode, symptoms may resolve in 1 to 3 weeks. Must be closely monitored with a narrow therapeutic serum range of 0.6 to 1.2 mmol. Serum sodium levels should also be monitored for hyponatremia. A 42-year-old male was recently diagnosed with bipolar disorder after his partner became concerned about his extreme highs and lows in moods. His high mood swings were often associated with grandiose ideas, gambling, risky sexual behavior, and shopping sprees that were causing the couple to go bankrupt. The physician prescribed lithium. 1. The client states, "The doctor told me I am having manic episodes." What does that mean? What is the nurse's best response? 2. The nurse knows that there is a risk of lithium toxicity. What are the symptoms of lithium toxicity and how will it be prevented? 3. The client's partner asks, "How quickly will the lithium work? What is the nurse's best response?" Note, answers to the critical thinking activities can be found in the answer key sections at the end of the book. 8.9 Antipsychotics. Antipsychotic drugs are used to treat drug-induced psychosis, schizophrenia, extreme mania, depression that is resistant to other therapy, and other CNS conditions. Antipsychotics are sometimes referred to as tranquilizers because they produce a state of tranquility. First-generation antipsychotics, also called conventional antipsychotics, have similar mechanisms of action. An example of a conventional antipsychotic is haloperidol. Conventional antipsychotics have several potential adverse effects, and the selection of a medication is based on the client's ability to tolerate the adverse effects. Second-generation antipsychotics, also referred to as atypical antipsychotics, have fewer adverse effects. An example of an atypical antipsychotic is risperidone. Both conventional and atypical antipsychotics have a black box warning indicating that elderly clients with dementia-related psychosis treated with antipsychotic drugs are at an increased risk of death. First and second generation antipsychotics. Mechanism of action. All antipsychotics block dopamine receptors in the brain. However, the precise mechanism of action has not been clearly established. Conventional antipsychotics, such as haloperidol, block dopamine receptors in certain areas of the CNS, such as the limbic system and the basal ganglia. These areas are associated with emotions, cognitive function, and motor function, and blockage thus produces a tranquilizing effect in psychotic clients. However, several adverse effects are also caused by this dopamine blockade. Second generation, or atypical antipsychotics, block specific dopamine 2 receptors and specific serotonin 2 receptors, thus causing fewer adverse effects. Conventional antipsychotics, such as haloperidol, block dopamine receptors in certain areas of the CNS, such as the limbic system and the basal ganglia. These areas are associated with emotions, cognitive function, and motor function, and blockage thus produces a tranquilizing effect in psychotic clients. However, several adverse effects are also caused by this dopamine blockade. Second generation, or atypical antipsychotics block specific dopamine 2 receptors and specific serotonin 2 receptors, thus causing fewer adverse effects. Indications for use. Haloperidol is primarily indicated for schizophrenia and Tourette's disorder. Risperidone is primarily indicated for schizophrenia, but is also used for acute manic episodes and for irritability caused by autism. Some atypical antipsychotics are also used as an adjunct therapy for depression or nausea. Nursing considerations across the lifespan. Elderly clients with dementia-related psychosis treated with antipsychotic drugs should be closely monitored for signs and symptoms of cardiovascular events or infections, such as pneumonia. Haloperidol is contraindicated in clients with Parkinson's disease or dementia with Lewy bodies. Clients who are concurrently taking lithium and antipsychotics should be monitored closely for neurotoxicity, and symptoms should be immediately reported. Adverse side effects. Elderly clients with dementia-related psychosis treated with antipsychotic drugs are at an increased risk of death due to cardiovascular or infection-related causes. Conventional antipsychotic medications have several potential serious adverse effects, such as tardive dyskinesia, neuroleptic malignant syndrome, and extrapyramidal symptoms. These adverse effects are due to the blockage of alpha-adrenergic, dopamine, endocrine, histamine, and muscarinic receptors. For additional details about these types of receptors, see the autonomic nervous system chapter. Figure 8.8 describes adverse effects associated with conventional antipsychotics. Clients should be warned to not consume alcohol and that their ability to operate machinery or drive a vehicle may be impaired. Figure 8.8 Potential adverse effects of antipsychotic medication. Adverse effect definition. Tardive dyskinesia. Involuntary contraction of the oral and facial muscles and wave-like movements of the extremities. Neuroleptic malignant syndrome. Potentially life-threatening adverse effects, including high fever, unstable blood pressure, and myoglobinemia. Extrapyramidal. Symptoms treated with anticholinergic medications such as benztropine and triaxiphenidil. Second generation, or atypical antipsychotics are less likely to cause adverse effects but have the potential to do so. Atypical antipsychotics may also cause metabolic changes such as hyperglycemia, hyperlipidemia, and weight gain. Client teaching and education. Advise client to take medication as directed. Medication doses should be evenly spaced throughout the day. This drug may take several weeks to manifest desired effects. Clients should be advised regarding the possibility of extrapyramidal symptoms and that abrupt withdrawal may cause dizziness, nausea, and vomiting, or uncontrolled movements of mouth, tongue, or jaw. Additionally, the client should be careful to avoid alcohol or other CNS depressants while using the medication. Medication card comparing antipsychotics. Now, let's take a closer look at the medication grid for haloperidol and risperidone. Medication cards like this are intended to assist students to learn key points about each medication. Because information about medication is constantly changing, nurses should always consult evidence-based resources to review current recommendations before administering specific medication. Basic information related to each class of medication is outlined below. Prototype or generic medication examples are also hyperlinked to a free resource at DailyMed. On the homepage, enter the drug name in the search bar to read more about the medication. 3. This work is a derivative of DailyMed by U.S. National Library of Medicine in the public domain, comparing types of antipsychotics. 8.10 Anticonvulsants. Medications used for seizures are called anticonvulsants or anti-seizure drugs. Anti-seizure drugs stabilize cell membranes and suppress the abnormal electric impulses in the cerebral